So the risk of progression or the rapidity of progression depends upon the initial peak LV outflow tract gradient. Anything more than 10 millimeters of mercury progresses very rapidly. So it is like LV outflow tract obstruction begets LV outflow tract obstruction, like any MR or AF. There is some degree of aortic regurgitation in almost 50% of cases, while more than moderate AR in 15% of cases, which require additional repair of the aortic valve if there is a cusp prolapse or redundancy. This is because of the hemodynamic stress of highly turbulent flow hitting the aortic valve leaflets. But unlike bicuspid aortic valve related aortic regurgitation, there is no post-stenotic dilatation because there is no medial weakness. Unlike in bicuspid aortic valve, the tunica media is intact, so there is no post-stenotic dilation. The risk of infective endocarditis because of the damaged cusp. The second type of fixed subaortic stenosis is the ridge type. So this ridge is a fibromuscular tissue starting 1 centimeter proximal to the aorta, starting at the level of the ventricular septal crest. So it can engulf the LV outflow tract. If it is severe, it is called a fibromuscular collar or a tunnel, which is more than 25% incidence of SAS. So what happens here? There is anterior and posterior portions of the LV outflow tract which are bowing towards. So the LV looks like a banana. Both the anterior posterior portion will bow towards each other, creating a tunnel. So it can be hypoplasia of the LV outflow tract. So this fibrous proliferation or muscular proliferation starts at the interventricular septal crest. So this is the aortic valve. It can be anywhere from 1 centimeter near or distal to the aortic valve. It forms a fibromuscular collar or a tunnel. So here it is very pinhole like. So significant outflow tract obstruction, and it is involving the anterior mitral leaflet also. If you can see the PML, it is fibrous, while here it is fibrous and muscular. So it has involved the interventricular septal crest, forming a tunnel or a collar, and involved the AML also. Clinical features, to keep it simple, the features are similar to aortic stenosis, but two major differences are there is no ejection click, unlike aortic valvular stenosis which is seen in bicuspid aortic valve, and there is no post-stenotic dilatation unlike bicuspid aortic valve, because in syndromes like bicuspid aortic valve, Marfan syndrome, there is intrinsic tunica media disease resulting in dilation of the aorta, which is not seen here. And any amount of AR is seen in 50% of cases, and moderate or severe AR is seen in 15% of cases. So there is left ventricular hypertrophy, as you can see by the tall R waves in lateral precardial leads, and strain pattern where it is called a arrowhead or a asymmetrical pattern of T inversion. So wherever R is tall, you are seeing the T inversion, asymmetrical T inversion, which is called the strain pattern because of LV hypertrophy. So lack of Q waves in V4, V5 mean there is no volume overload. It is a pressure overload situation. This is a better view of the M mode of aortic valve. So here this is the open valve, that is systole, and there is early systolic notching, closure. So even before the systole ends, it closes, and then there is fluttering of aortic valve. There is aortic valve here, and there is a membrane which is incomplete or will give a crescentic opening. There is hypertrophy of the posterior wall and the interventricular septum. Color Doppler is showing a turbulent flow starting well before the aortic valve, and there is turbulence seen even in the right ventricle, means there is communication between RV and LV. So in this case, there must be a VSD.